Hi friends, welcome once again. I am Dr. Moez Kakiani from Mumbai, India. Today I will be talking to all of you all about a new product that has been designed and launched by MIK Dental. The product that is closest to my heart, this is Unwind MD. What you see in front of you, friends, is a specimen of the very same. Friends, this is a prefabricated anterior deprogramming splint. It is to be relined with any material that sets hard. This could be a bite registration paste or cold cure acrylic, and it is supposed to be custom fit to your patients on the maxillary anterior teeth. What it essentially does is it deprograms the mandible and allows for muscles to relax, thereby providing for what we call as peaceful neuromusculature or coordinated muscle function. Because it works so brilliantly, friends, in relaxing musculature, it has a broad spectrum of indications. The first of which is diagnosis. How often do we have patients who come in with orofacial pain and we are not sure of exactly what the origin is? The beauty about this product is once you have the patient wear the deprogrammer for a few minutes, probably a few hours, maybe even overnight, it will help you understand whether the problem is an occlusomuscle disorder, which is a problem with occlusion and something that affects the muscles, or is it a true temporomandibular joint disorder, either of which will require completely different treatments. What it also tells you is the pain that the patient feels of dental origin, or is it beyond the realms of our treatment as well? So that's the first indication, which is diagnosis of orofacial pain. The beauty about this product is it also works for patients who may have what is called as tension type headaches, frequently termed as migraine pain. A lot of these patients often suffer for years and years together, only having taken medication to symptomatically treat them, because medicine per se has no answer to what the problem is, where does it lie, and therefore there's no definitive treatment. A lot of times what's important to understand is migraine headaches could be caused because of an imbalance in the muscles in the panfacial region. A lot of times the etiology or the cause for this lies in the patient's actual bite. If the occlusion is not correct, in technical terms, if the centric relation and the maximum intercuspation do not coincide with each other, which means if a patient has a hit and slide occlusion, they are susceptible to migraine headaches. If an individual who has these kind of headaches were to wear this deprogrammer through the night and probably even through the day when they are in stress, which means when they are clenching or grinding and they know it, this could be when you're driving a car in traffic, this could be when you're watching television or a serial or a sports activity, you may start clenching and grinding. That's when a lot of these headaches begin. Even if these headaches were to begin as those written, I get up in the morning and I have a headache, doc. That's where something like this works brilliantly. So migraine prevention is again one of the primary mandates of this particular appliance. The next indication for this appliance is patients who are bruxers or clenchers. We're aware of the fact that most of these activities are nighttime. A lot of these patients who need aggressive full mouth rehabilitations may probably not be able to afford or get the treatment done at that time. In such patients, it's very important for them to protect the teeth, especially at night. We unfortunately give a lot of these patients something that are called as night guards. These are soft appliances, friends. When you put something soft into the patient's mouth, the first thing that a patient wants to do is chew on them, which means you're actually worsening the situation or the condition for the patient. Also, it does not help improve the bite. It simply merely acts as a cushion. What happens with this particular appliance is it disoccludes the back teeth, which means it allows only for the front teeth to touch and separates the posteriors from contacting. Thereby, there is no contact, there is no friction between the surfaces, so attrition or wear because of bruxism or clenching dramatically decreases. But what's more important, it allows the muscles to relax. Thereby, such patients even get up feeling more refreshed. They get up feeling, oh, you know what, I've had a good night's sleep, which is one of the primary concerns in a lot of these patients as well. The next indication for this appliance is when you plan to do complex full mouth rehabilitation cases. We are all aware of the fact that such cases need to be done at ideally a centric relation position, which is a neutral position for the body. Having worn this appliance for a few hours or maybe even a few minutes, 99 to 100% of your patients will go back into centric relation provided the joints are in a stable condition. It is also beautiful to protect your full mouth rehabilitation cases. Imagine you've done a complex full mouth. If your patient continues to clench or brux, which is centrally mediated, after the treatment your FMR is going to fail. That's where the patient essentially sleeps with this appliance at night, thereby protecting the teeth. Imagine a situation where you want to do occlusal equilibration. The patient has to come in centric relation. That's where overnight wear of this appliance works brilliantly. It's also indicated, friends, in those patients who have clicking in the joints, may or may not have pain. It's important to understand here that all temporomandibular joint disorders are progressive in nature. Once there is a click in the joint, which means the pathology has begun. If you leave it untreated, it will progress from stage to stage and cause much more pain, and more aggressive treatment will be required later in life. If you were to give this appliance to the patient to sleep at night, it protects the joint, it protects the muscles, and it prevents from the effect of the imbalance in the occlusion to cause much damage to the patient in the long run. In a few patients, friends, the Unwind MD is all that they need. In a lot of others, this is usually the first step in achieving peaceful neuromusculature, after which starts complex rehabilitative procedure. Let us understand how, first, this appliance is supposed to be used, and second, what is the mode of action, or what is the concept behind this small little piece of acrylic working so beautifully for so many wide indications. This is a representative image of the Unwind MD. Let's look at the appliance from different angles to help understand the construction of the same. First, let us look at the labial view. This is the surface that juts outside the patient's mouth when the appliance is seated in its correct position. A couple of things that I want to highlight here. First is the labial face is absolutely smooth, thereby allowing the patient to close the lip without jutting and interfering with the same. The other thing is the small little notch that has been provided here. This is so that the labial frenum can seat here without hurting the soft tissue. Looking at the appliance from the side view, this is representing the internal cavity of the appliance. It is this area which is relined with a hard setting material, which means when the appliance is in place, this is where the maxillary central incisor will go and seat. Two things that I want to bring to attention in this image is, first, the internal cavitation has been made relatively wide, which means this area will allow for you to place the appliance in patients who have a angles class 1, angles class 2 or an angles class 3 malocclusion, making this in a lot of senses a universal appliance. The second thing is the flat surface that you see here is called as the disoccluding table or the DT. Now, what is important in a patient who is wearing the appliance is that the DT is supposed to be absolutely parallel to the maxillary occlusal plane. This is achieved intraorally with the help of what is called as a DT aligner. That's the DT aligner. You see it in the middle of your screen right now. Moving ahead to the next view, this is now looking at the appliance from the rear side. What I would want to bring to attention in this image, again, two things. First are these retentive undercuts that are provided, two towards the front and one towards the back. This helps retain the material that is used to reline the appliance. One of two materials can be used. If an acrylic material is used, these grooves are not going to help much. But a lot of times I do give the appliance to the patient for a short duration. In such a scenario, I may reline the internal cavity with a bite registration paste. So first I apply triadhesive everywhere and then put in the paste. The advantage with these grooves is the bite material will now extend and mechanically get locked into these, thereby holding the material and not pulling off. The second thing that I would want to bring attention to here is the labial face, which is nice and tall, which allows for the material to go and lock into natural hard and soft tissue undercuts, thereby retaining the appliance, and the appliance does not keep falling off in the oral cavity. However, the palatal face here is relatively short. This adds to the comfort of the patient because it does not restrict the tongue space, nor does it affect the speech as much as other appliances would. The last or the functional surface of the appliance is the incisal view. What you see here, friends, is the disoccluding table. This disoccluding table looking right here is the portion that you see at the tip. It is on this table where the lower incisor goes and contacts, thereby separating the back teeth. A lot of times, patients come to us with incisors in the lower arch which are crowded, or they may have diastemas between the same. In such a scenario, if the patient were to make any excursive movements, the lower teeth may go and get locked at the edges of the disoccluding table, not allowing the mandible to relax the way it desires. What can be done in such a situation is this disoccluding table can be widened by reducing it with a denture burr. Now, here you can see the disoccluding table widens progressively upwards. So if I were to trim this edge with a burr, what am I doing? I am simply widening the disoccluding table. Now, if I have widened the table, even if the lower anterior teeth are crooked, they will still have maneuvering space without getting restricted. And the same philosophy even works for teeth that have large diastemas between them, or if the patient may have a mandibular incisor which is missing, that again works against the appliance. So if you were to simply trim this surface off, the appliance works as a flat, long, relatively wider disoccluding table, once again making the entire appliance universal in indication. In the next segment, let us actually look at how this appliance is customized. Friends, here we have a patient who has been suffering from migraine headaches for a long time. We're going to attempt at customizing the Unwind MD for him. The primary goal in the use of the anterior deprogrammer therapy is it should separate all the back teeth. So before you actually go ahead and reline the internal cavity of the deprogrammer, first always check if the deprogrammer is separating the back teeth adequately or not. So I will seat this in the midline and have the patient bite down into this. First, make sure you ask the patient, in static occlusion, is there any contact in the back teeth, yes or no? Friends, is there any contact? No. Alright, then you stabilize the appliance and have the patient move the jaw forward and back. If you could move forward, please. Forward, 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 and back again. Was there any back tooth touching when you do this movement? No. Alright, now if you could move towards one side and back again. Move towards the other side and back again. Fantastic. In any of these sideways movements, was there any back tooth touching? Fantastic. It's important that in static and dynamic mandibular movements, no back tooth comes in contact, including the canine teeth on both sides. This is the primary goal in deprogramming: separation of the posterior teeth, allowing only the mandibular anterior teeth to touch the appliance. So what we will do now that we've checked the appliance, we will reline this internal cavity of the appliance with a hard setting material. What I prefer is cold cure if it's for long duration, which is the case in this patient. If it's for a short duration, you could reline it with some bite registration paste, which is again a hard setting material. So here I have relined this with some cold cure acrylic material. I'm going to place it onto the maxillary central incisors. Please make sure that this goes into the midline. Seat it, but not all the way. Now it's important at this time, friends, that the disoccluding table, which is the portion of the deprogrammer on which the lower incisors contact, is absolutely parallel to the occlusal plane. For the same, here at MIK Dental, we have come up with a metallic plate that we call the DT aligner. All we do is we seat it onto the occlusal surface and have the patient bite down into this place. Just bite down and press all the way. Perfect. What this does is it automatically aligns the entire disoccluding table to the occlusal plane, thereby adding predictability to our work. Now what's important when you reline with cold cure acrylic is that you do not allow for the material to polymerize completely, because then it's difficult to retrieve the deprogrammer. So the moment it begins to release heat, that's when you remove it and you put it in hot water. What this does is it allows for the material to polymerize faster and with less amount of shrinkage, and also it decreases the number of voids inside. So the moment it begins to generate some heat, open please, all we do is we remove this deprogrammer from the patient's mouth and we put it in hot water. So all we do next is we trim the excess acrylic resin. This is how the deprogrammer at the end should look. There should be no excess flash coming out from any side. Once again, you go ahead and you seat this in. It should not be too tight. At the same time, it should not be extremely passive for it to fall down by itself. Have the patient bite down into this, bite please, and tap, tap, tap your teeth together and move your jaw forward and back, left and right, left and back, right and back. In any of these movements, is there any back tooth that is touching? Perfect. So let us understand, friends, what a dental interference is all about, what are its ill effects, and how does the body essentially adapt or cope to the presence of an interference. I'm sure all of us will have related to this one patient where we may have seen a third molar that is super erupted, or we may have done a composite restoration on the occlusal surface, or we may have cemented a crown that fits a little high. In all of these, my patient may tell you, doc, this feels a little high. Unfortunately, in most of these circumstances, we'll end up telling the patients, you know what, just give it a couple of days, it'll settle down. Let us understand what this settling is all about. First things first, friends, what is an interference? An interference is any portion of a tooth that prevents the rest of the teeth from coming into unanimous and uniform intensity contact at the same time. So what happens is, as an individual tries to close the teeth together into maximum intercuspation, this tooth that kind of stands above the occlusal plane hits first. This results in what we have read as trauma from occlusion, TFO. The moment a particular tooth comes in contact prematurely, the periodontal ligament of this tooth, which has these proprioceptors or mechanoreceptors, they immediately send a signal to the brain, primarily to the trigeminal ganglion. The moment this signal reaches the trigeminal ganglion sends a signal to the lateral pterygoid muscle, telling the lateral pterygoid, which is a positioner muscle of the mandible, to contract very slightly. What this does essentially is the individual changes the path of mandibular closure into a pattern which avoids that premature contact, thereby now re-establishing a new maximum intercuspation for our patient. And that's how the crown actually settles. Settling happens at the level of the lateral pterygoid muscle. Now, simply put, I'm sure all of us have experienced this one point where the road has a pothole. We may have driven across and bumped into that pothole. The next time we walk across that or we drive across that, we know we don't want to hit that pothole. So what do? We avoid it by slightly altering our path. That's exactly what the mandible does. If the mandible realizes that there's one point of one tooth that is in premature contact, it changes the path of closure to avoid that. And that's how the crown settles. A lot of times this settling may not be physiologic, and an individual may start developing signs and maybe eventually some symptoms of what is called as muscle discrepancy, or a discrepancy that's present between physiologic jaw position and the habitual jaw position that the patient has developed with time. In such a patient, what is required to get the patient into original comfortable occlusion is what is called as deprogramming. This can be done with the help of an anterior deprogramming splint. That's exactly what an Unwind MD does. When you place the Unwind MD onto the anterior teeth, what its role is essentially is to separate the posterior teeth. Essentially, it disoccludes the back teeth. The moment the back teeth are disoccluded,
the signal that is going to the brain from the periodontal ligament is intercepted. The tooth no longer hits prematurely because none of the teeth actually hit. What this does is it actually tricks the brain. It tricks the brain into believing the interference is gone. So what does the brain do? The brain no longer sends a signal to the lateral pterygoid. What does the lateral pterygoid do? It relaxes. The moment the lateral pterygoid relaxes, the condyle goes back into home, which is nothing but centric relation position. Now your patient has what is called as peaceful neuromusculature. It's just a lot of coordination that is present between the elevators and the depressor muscle. If your patient comes in with symptoms, say of migraine headaches or tension type headaches, deprogramming will relax the musculature, thereby taking care of the symptoms. The moment you remove the unwind, what essentially happens is the brain no longer is sending a signal to the lateral pterygoid, which means the path of closure is towards centric relation. As the individual now closes, that premature contact now starts hitting all over again. If you allow for this to stay, the muscle engram is back because the lateral pterygoid now begins to protect the entire system. So what an anterior deprogrammer essentially does is, by tricking the brain, it helps us clinicians identify the first point of contact in CR, what we call as centric occlusion, and that's the point where the interference begins. Now imagine a world where we remove this interference. This could be, let's say for example, it's a high crown, we remove the crown. If it's a high filling, we adjust the filling. If it's a third molar that's supra erupted, we extract the third molar. What have we done? We've removed the cause of slide, which is the interference. The moment you do that, the brain no longer needs to be tricked because it is permanently deprogrammed. Such a patient is said to have coordinated muscle function, which means the centric relation is the same as maximum intercuspation. Signs of breakdown decrease, most definitely the symptoms go away. Here again, what is the anterior deprogramming done? It has worked as a diagnostic tool, helping us understand where the problem lies, thereby directing us towards its correct treatment.
Right, so that is, friends, all about Unwind MD, the anterior muscle deprogrammer from MIK Dental. Give it a try. You will be amazed at how such a small little appliance works for such a wide variety of clinical situations. What's important to understand, friends, is this is a removable appliance, which means at no point will it do any irreversible damage to the patient. As long as the joints are stable, this appliance will not hurt the patient at all. It may or may not improve the condition, thereby helping you with the diagnosis, but it will not hurt the patient as long as the joints are stable. Do give it a try and you will be amazed at the beauty and the ease with which this appliance works. Once again, friends, if you like this video, please share it with your colleagues. Subscribe to our channel so that you are updated regularly of our videos and products. And until we meet again, wishing all of you all the very best in life. Bye-bye.